Hello? The original video was removed by YouTube, so I had to re-upload the video on another website. Please follow the link in the description.
Now let's move on to the protocol at your institution. It's going to be different for everyone, but there's some baseline research and experience that went into that, and some of that you have to understand. Now remember, 2/3 of all patients that you will see will be on some form of oral hypoglycemic. Now there are quite a few of them. I just want to mention two groups, the biguanides, of which we have metformin. Now those are sensitizers, so they'll sensitize the body tissues to insulin. And they also decrease glucose production. They have a very low risk of causing hypoglycemia, but they do have a risk of causing lactic acidosis in sensitive patients. For us as surgeons, we might be worried about the patients with renal insufficiency and sending them to get contrast at radiology. The sulfonylureas, like the second generation glipizide, now these are secretagogues, so they're going to stimulate the release of insulin in those patients that can still produce a bit of insulin. They do have a high risk of causing hypoglycemia, so watch out for them, and their side effect really is weight gain. Now, 1/4 of your patients will be on insulin, so those will be the type 1s, they require insulin, but many type 2 diabetics are also on insulin. Now, when a patient is on an insulin regime, it's really trying to mimic the normal physiology. So they'll get a type of insulin just as a baseline. You have a normal basal metabolic rate even if you don't eat or do much, and that requires some throughput of glucose metabolism. So there's this basal rate, then there's an increased rate of insulin just to take care of the carbohydrate intake that follows meals and to deal with that carbohydrate load. And there's also, from time to time, we also need a bit of rescue therapy. It just might be that the patient ate something abnormal, or they suffer from a bit of infection called flu or cellulitis or something like that. So the baseline insulin, you really can do that as two types. In first world setting, many patients have subcutaneous continuous infusion pumps, but for the rest of us, there's this long-acting peakless insulin. So there'll just be a slow, long release, so there won't be any peaks. And really 50% of the daily insulin dose should be of this type. Now for your type 2 diabetics on oral medication and the insulin, most of them require a bit of higher dose of insulin because remember they are insulin resistant. And they, together with the type 1s, get a mixed dose. So they'll get a long-acting, intermediate acting, short and a rapid acting insulins made up as a mixture. And you've got to watch out for the different types that they're on. So what can you suggest to patients, or what is usually in these algorithms at your institution? Let's start with the day prior to surgery. Now on that day, they just take their normal dosing. Nothing happens on the day before. There are a few exceptions though, watch out for those. If patients do take an evening dose, remember some patients will just take one day a dose, but most people will be on at least twice a day dose. For those patients that then take an evening dose and do suffer from nocturnal hypoglycemia, in other words, they do have to get up and eat something during the middle of the night, they can decrease their evening dose. They should actually decrease that evening dose slightly by about, say, a fifth to a third, somewhere in that range. Just decrease that evening dose. If they are type 2 and they are only on peakless insulin, that baseline insulin that they take, long-acting insulin, so type 2 oral and only on long-acting, they can omit any kind of evening dose that they take. They can omit any kind of evening dose. The patients at type 2, so they're an oral and some mixture of insulins, they can still take that evening dose because they will get that peak before they actually go to bed. So they can still take that evening dose. Evening mix, any type of evening mix, but the patient also suffers from hypoglycemia if their breakfast is delayed, which is going to happen. They're going to have to omit breakfast. They can also decrease their evening mix dose. So watch out for these patients. Now we get to the operative day. Now, no oral or non-insulin drugs should be taken on the day of surgery. So that gets omitted. Now remember, we try to operate diabetics in the morning, so they're not going to have any breakfast. We also advise patients to bring along their own medication. Now the surgical anesthetic and nursing staff can actually confirm what the patient's on, and it confuses any dosing issues that the patient's not sure of, or some trade name problems. It really helps to prevent that confusion. So if it's a very short procedure, you can just omit all their morning doses. They go for the procedure, their glucose is monitored every hour, and they can just eat afterwards. Now, in any longer procedure, or there's going to be a long wait, a long delay, either in getting to the surgery or for them to be able to start eating post-operatively, always consider giving these patients intravenous glucose. A diabetic also needs glucose. Okay, so they're going to get a glucose-containing intravenous line. Now, also with the longer procedures later on in the morning, Van et al. Worked out a beautifully easy formula, pure algebraic formula there, easy to do. Published in 2009, well worth a read. So it works the following way. So you take the normal interval that the patient takes their regular dose at. Some people, as I mentioned, take insulin once a day, so their dosage interval would be 24 hours. Some patients take insulin twice a day, so their dosing schedule is 12 hours. You subtract from that, 24 or 12 or whatever, the estimated fasting interval. So say for instance the patient usually takes their morning dose at 8 o'clock. They are only expected to be able to eat by 1 this afternoon. Their case is at about 11, and they're going to come out of theatre, and by about 1 o'clock they should be able to eat. So what you would do is this 8 till 1 o'clock, that's 5 hours. That 5 you subtract from that interval time, 24 or 12, just subtract that from the normal interval and divide it by that normal interval, and that gives you the fraction of the morning dose that they should then have. So let's be clear, if they're coming in for a short procedure, first thing in the morning, and within an hour or two they'll be able to take, you can just omit all their glucose. If it's going to be longer before they can eat, or longer procedure, or longer delay before they get to, you have to give them some insulin in the morning, together with putting up a drip for them so that they can get intravenous glucose. And for them you are going to give a certain dose, and you can work out the fraction of the dose that they would usually take in the morning. So that little algebraic formula there, you'll use that, and that works out the fraction of the morning dose, which is then giving usually as an intermediate acting insulin. Now, if there's any longer delay, or patient has a type of procedure which there are going to be null pos afterwards, some abdominal procedure like a colectomy, now we really have to consider putting them on a sliding scale from the get-go. Now, the sliding scale is very individualized. We usually have these written up as a protocol, but there's something that underpins that protocol or algorithm that you have in your unit. It works like this. Take about 1,800 or 1,500 in patients who are more insulin sensitive, and you divide into that their total daily dose of insulin. So if they get 35 units per day or 40 units per day, divide that, that becomes the denominator, divide that into your 1,800, and that will give you, in milligrams per deciliter, the amount that their blood glucose level will be lowered by giving them 1 unit of fast-acting or rapid-acting insulin. Okay, I'll say that again. So you take 1,800 divided by the total daily units of insulin, and that will give you the lowering capacity in milligrams per deciliter, the amount that their blood glucose levels will fall if you give them 1 unit of ACT rapid. That is what underpins, because it's different for every patient, underpins a generic sliding scale. Once again, you can multiply that value by 0.0555, and that will give you the millimoles per liter. So you can work out by how much you want to decrease that, and by that you can work out how much insulin to give them. That is what underpins, and that is where you get this generic sliding scale from. Now remember, in all these surgical patients, you have to regularly check their blood glucose levels, at least every hour. These patients demand more resources. You have to watch them preoperatively, intraoperatively, postoperatively. Never forget hypoglycemia though in these patients. We know with that very tight control, patients do suffer from hypoglycemia. If they were switched to just normal saline in the IV line, they continue to get some form of insulin, they can get hypoglycemic. Watch out for those. Be ready with 50% dextrose water as a small bolus dose, or then just switching over to glucose containing 5% dextrose water, for instance. Watch out for fluid shifts. Surgery causes fluid shifts. If patients have high blood glucose levels, they're going to have an osmotic diuresis. So be on top of their fluid requirements. Be on top of the electrolyte disturbances. Glucose plus insulin will give you a movement of potassium into the intercellular space. So watch out for those disturbances. Very lastly, just a few words on hypoglycemia. Now, different patients experience hypoglycemia differently at different levels, and in each patient, different levels on different days might cause hypoglycemia. So it's not this absolute cutoff. First of all, they'll get this adrenergic response, they'll get hungry, they'll get tremors, they'll get palpitations, and then the more important neuronal deficits as the neurons are starved of glucose. And remember, your neurons can only burn glucose as an energy source, and they can become comatose, delirious, they can get convulsions. Usually all starts off by fatigue though, and this does carry morbidity. They can develop damage to the neuronal tissue and even mortality. So if they're awake and they can take orally, give them a sugary drink. Don't give them tablets containing sugar, so you might have solution, creating a solution problem, or there might be precipitation. So give them a sugary drink, or if they can't take, give them intravenous fluid. And then monitor their blood glucose levels at least every 15 minutes. So the diabetic patient is important. It takes a lot of effort and resources, but put that into your diabetic patient and understand why that algorithm works the way it does in your patient. And if you have to change it slightly to individualize care, remember these things that I've mentioned in this lecture.